Hello, everybody, and welcome to the Joyscape Therapy podcast. I am your host, Marissa McKenzie. I am a BCBA. Our slogan here that I'm kind of, just messing around and trying to pick up on a slogan that's going to stick here. I love the idea of like everyday behavior for everyday people. And I want everyday people to also include, professional, BCBAs, SLPs, right? But I do want to make sure that we are still, user-friendly enough to outreach to those that, aren't necessarily connected professionally, and that have just kind of a personal interest or, want to learn more. So with that being said, I think it is important to break down a few of the acronyms that you might often hear us say here. So I am a board certified behavior analyst. That's, you'll hear BCBA. And what that entails is I have a master's degree. I've studied a specialization in applied behavior analysis. And just to kind of sum it up a little bit is we look at how our environment, our learned experiences shape our behavior on a day-to-day and a larger scale. And we apply data to that. We look at function of behavior. So when we're talking about a BCBA, this is a clinician who they don't just work with the autism population. There's expansion in many areas now, which we did mention in our first episode, so feel free to listen if you do have some time. But there's a vast majority, because of the high demand of the need for therapy for the autism population, that you will likely find BCBAs that have experience or are currently working with the autism population. So with that, as a BCBA, you complete your master's degree, you complete supervised field work, you're supervised by another BCBA within that process. And then when you graduate and have your fieldwork hours completed, you are able to sit for an exam, which you need to pass. And then you're able to practice. So what does that mean? Oftentimes, like I mentioned, we do work in ABA therapy. So that is basically if a child is diagnosed with autism, whether that be by a psychologist, by their primary, you might hear about like an ABA prescription, or a diagnostic report would be needed if it were conducted by a psychologist. Then you're going to be referred via insurance, most likely. And these are common pathways. It's not the only pathway, right? So after that process, then you would be referred to an ABA therapy agency. So within that, nowadays there's oftentimes a wait list. So access is another thing. So it brings me to our topic for today, which is basically breaking down the tiers of ABA therapy. And I mention this because as Joyscape Therapy, we are mainly located within the Bay Area, so California, Northern California, and we have a 2-tier model. So this is super unique because a lot of the agencies you're going to see just nationwide are going to be 3-tier models. So what is a 3-tier model? So as a BCBA is going to kind of be the person that assesses the child, right? So let's say your child, gets in via the wait list or what have you and finds an ABA therapy company. Then they will be assessed. There's multiple different assessment methods. We'll probably do a segment on that as well at one point or another. But they'll get assessed. And what you will receive is a clinical recommendation for therapy hours. And so unlike many other therapies like speech therapy, occupational therapy, ABA therapy has a larger allotment of weekly hours. So depending on the clinical recommendation, you could be looking at anywhere from, I don't know, 6 hours, or even parent consult, social group only, recommended. But it can range from, those lower intensity, such as parent training or social groups only, into, I say 25 hours. And I say 25 hours because I really hope that we are not still having clinical recommendations for 40 hours a week. And that's, again, another segment that we'll have to talk about, because it's a full-time job. And I think that when we're talking about sustainability and teaching, I think 25 hours for a high intensive need is more of the norm, what we might see now. And that should be paired with parent involvement and lots of coaching, education, training, and a fade out plan should be present. So we'll touch on those things a little bit more. But so you would have a BCBA, and then when we get into staffing, so let's say your child is recommended for 25 hours a week. Then we're going to look at, okay, how do we staff that? And generally in a 3-tier system, we're going to staff it via a behavior technician, or what's also called a registered behavior technician, RBT. And that individual is generally going to go through a 40-hour training process. They're going to be given, a few different, maybe more specific training on like data collection. There's several different interfaces that we might use, but pretty common ones, Catalyst, Central Reach, things like that. They may or may not sound familiar. And then they're going to get some overlap support, maybe some hands-on training to working with children. And then they're going to get, thrown in there, for lack of a better word. But you have that RBT who's working, may or may not have some experience working with children. And then you're going to have like a mid-level who's generally a higher, maybe a more experienced RBT, maybe in their master's program, maybe interested in behavior analysis, and just has a little more refined skills than you might see with RBT. So oftentimes that mid-level can provide direct therapy as well as the RBT. So obviously 25 hours per week for one child with one therapist is going to be rough, right? For both sides. It's nice we talk about generalization. So we do always kind of want to focus on any skills that we're teaching a child. We will also want to make sure that these skills can be translated not just with us. We talk about instructional control. When you build rapport and, you spend a lot of time with any individual, you're going to have a little more influence with them, and you're going to build a bond or, a good relationship. So we often refer to that as building rapport and instructional control. The expectations are pretty clear in that relationship one-on-one. So when we can see that these same methods of intervention translate to other individuals, then we call that generalization. And the most important individuals it should be transferring to are going to be families or parents, right? So a mid-level or a master's student RBT, a little more experienced RBT, is going to help overlap support, provide direct therapy, and also do a little bit of treatment planning. If they are in their master's program, this is probably going to be fairly common. The biggest thing is that then you have the BCBA. And in a lot of these 3-tier models, the BCBA is most likely not conducting any therapy with any direct therapy with any child they see. And some might, right? They might fill in here and there. But their caseloads are generally going to be larger. Ideally, hopefully not beyond the range these days. Again, we're a 2-tier model, so it's been a while for me, but I would say within the 10 to 15 range. Hopefully they're not going over 15 cases on for one BCBA. So if we break that down, right, if you have 10 kids and each kid has 25 hours a week, that is going to be extremely difficult to know that child, to know their family, to work with their family, and to support the behavior technician in addition to the mid-level. So you can imagine the task to supervise and manage a larger team like that can be challenging. And I think that's what we see a lot in a 3-tier model. And we are only our capacity is only so much, right? Not just we can be wonderful at time management, but even when we're talking about clinically, there are challenges, so we need support. So that's why a 3-tier model is most common, because you're able to provide, BCBAs can have more cases, they can help more families, and you'll have, support from RBTs and mid-levels. Again, we go back to the demand for support for ABA therapy is vast, and not just in our region. This is just nationwide. So I want to kind of get into the 2-tier model, or even there are some companies or independent contractors who are solely conducting therapy on their own, collaborating with other providers like speech pathologists, like occupational therapists, school educators, psychologists, right? It can vary. So in a 2-tier model, it's more manageable in the sense that we only have master's level RBTs and then BCBAs. And the unique thing about this is that BCBAs have a lower caseload, so they're actually conducting therapy with the client on their caseload. And this allows us to stay sharp on our own clinical skills, right? I mean, if I look at a program that I wrote and I look and I'm like, when I actually do it the way it was written, I'm like, I need to revise that, so I'm actually doing it. And these are things we can do in overlaps, just as a 3-tier would as well. Model a small intervention, right? Say we're talking about block imitation. And the desired response would be, stack 3 blocks, just 1, 2, 3, single stack. And say that is incorrect. The child responds incorrectly. So we have to have a prompting procedure. And the way we mark the data is the way that someone who's not conducting therapy is going to have to review this. So what they're going to rely on. So we do have indirect time. So just larger, kind of going into a little more complex of like, it takes more than just to say I did direct therapy or I didn't overlap, right? So we really get time to look at these things and break them down and use them in practice and revise them accordingly, with a little bit less demand and pressure from having, 10 other kiddos that we have to see. Same thing, each kiddo has one parent, a grandparent, or, 2 parents, 2 grandparents, 2 sets of grandparents, a nanny, what have you. There's just a ton of things to look into. And when we're talking about a kiddo with 40 hours, again, I'm saying, I hope that we are still able to, one, have a clear fade out plan for that child and the family that is transparent and understood of how we are going to progress and fade off, so that the family can then take over, so that natural supports can really take over and have the skills to continue the skill building that we hope to facilitate during our ABA sessions, right? So even still, as a 2-tier company, we are able to overlap our, we call them program managers, which hopefully we'll be able to get some on too, to just discuss their experience and what it's been like to have this just kind of different model. And it's beneficial in a lot of ways. And I do personally enjoy being active on my cases and kind of just feeling my way like through the ins and outs of their program, of their goals that I am setting. Yes. So I am familiar. Yes. But to actually do these and see like, if we probe it, probing is something we do and say, let's see if this kiddo knows it. Let's give that exposure and see if it's already known, or if it requires only, one teaching trial and then boom, this kiddo picks it up. So it's in their repertoire and they need least intrusive teaching, right? Like just some of the various things that are a benefit to when I see my client once, 2, 3, 4 times a week for 2 to 3 hours. So super, super impactful. And then, so single tier is obviously just the BCBA, right? So they are, maybe an independent contractor. But it would be not just an independent contractor that consults for like schools, right? And then, observes the child. So the single tier that I'm talking about is they are conducting direct therapy with the child. They are hands-on on a regular basis with the child and there are models like this. So my point of bringing up this, tier system, 1, 2, 3 tier system within our ABA kind of world is to help others understand like there are other options out there, and there's not a ton of companies doing this 2-tier, single tier model. And then you're also going to get into like billing, some billing challenges, right? So, it's much easier said than done, but there are BCBAs that are willing to conduct direct therapy, a lot like SLPs and OTs. There are benefits to, we want to outreach to as many people as we can. We want to support and provide services to as many, to as many families as we can. But we are also only individuals, right? So again, just to kind of keep that into perspective, but I hope that we are more willing to understand like our role as BCBAs, and, even in a 3-tier system, we can still conduct direct therapy and still get that hands-on clinical experience. And we use the common practice that we would use to provide feedback is BST, so behavior skills training, where you provide it in a written description, you discuss it, you role play it, then you model it, and then provide feedback, and then vice versa with the other individual. So this is a really good method, because I think that when we're talking about parent trainings and parent coaching and how to feedback from ours, and the essential pieces to, if we do a 2-tier model, and although we can't all at once intake as many families as a 3-tier model, the idea is that we're in a more intimate setting where we can provide the quality therapy with lower rate of turnover. We haven't even discussed that. Turnover is just a huge thing, right? I mean, you might have an RBT or even just the behavior technician coming in who it's like, oh, cool, great, a job. Maybe they're right into college, and, they're just kind of right out of high school into college, and they're like, oh, this seems like a really cool job. I have experience working with children. I might really like this. And then they have the training, and, they realize like, oh, the data collection piece alone and the behaviors, like some of the reality to it is it's a complex job in the sense that it's more than just hanging out with kids. We'll do a segment. I want to do a segment about just kind of like what our job is on a day-to-day, because I think it's cool also in the sense of a lot, even for my family, telling them what I do is like, oh, Marissa works with kids, which is true, but there's so much more to that. Right? We all know, if you've worked with kids, you know that you do so much more than just, working / playing with kids. Although that is part of it, it doesn't entail the full scope of your focus as a BCBA. And so even as RBT, right? So when we're talking about turnover, we're talking about those nuances, those ins and outs that are so intricate sometimes. And, it tests your patience, right? A lot of the times our children with autism, they have challenges with speaking. They might not speak at all. And sometimes their mode of communication might be aggression. It might be spitting, right? So that requires an understanding of the individual, of what your role is. So it's important to ensure that from every level, whether you're a 3, 2, 1 tier, that you have the support you need to address these things. And turnover is a huge thing in a 3-tier system. A little bit less in a 2-tier, because you, like I said, you have those master students as mid-levels who have a little bit of more intrinsic motivation, right? Like they're in the field they want to be, or a related field. And so they're going to have a little bit more on the table in terms of, I kind of experience-wise, also knowing what their goal is ultimately, whether it is to become a BCBA or to become licensed in another similar field. So you're going to see less turnover. And that's a big thing at 3-tier companies, is turnover is huge, not just for RBTs, but for BCBAs as well. There are BCBAs holding over 15 cases, trying to support and train over 10 to 12 to 15 different RBTs, who is never, in master school, they do not give you a manager role school or class. So, again, you're managing a lot of pieces, right? You're collaborating. So you're coming into this like, oh yeah, I know how to do an assessment. I know how to work with children with autism. And again, this is my scope that I'm speaking from. So we don't just work with children with autism. But you go in and then you're like, okay, let's see what's going on. So burnout is a thing, another segment we will touch on, because it's relevant, not just to our field, but in general, right? To be able to set boundaries. So it brings me to, again, just to open up the scope of how we're practicing now as BCBAs, and that although it's not super common yet, I do hope that our field is going in a direction where it is able to support this type of model, and that we are continuing to support BCBAs in a way that still promotes their creativity as clinicians, but also focuses on, honing in on the practice of what we do, the science that we implement. And, I'm hoping that ways like this, through this podcast, is going to outreach and capture the attention and hopefully add some, a spark. And I hope that you took from this is that, there's so many outlets and ways to do things. So thinking outside of the box is really cool. And I hope that more people are open to just different ways to outreach into the community that needs support, education. I would love to see like group trainings for parents, and some of it is also BCBAs going out on their own, or providing the expertise that they have already in their skill set, and just expanding in creative ways that suit them. And this podcast is also an example of that. So I thank you so much for taking the time to, and please don't forget to download, check us out, iTunes, Spotify, and thanks so much for listening. Have a great rest of your week.